Welcome, everyone, and thank you for joining us for today's webinar. My name is Dr. Alexander Vigo Valentin, and I'm the Public Health Advisor and Hispanic Latino Health Policy Lead at the U.S. Department of Health and Human Services, Office of Minority Health. Today's webinar, what's in it for you? The importance of Latino representation in research studies is in observance of Hispanic Heritage Month. The Office of Minority Health, in collaboration with the National Institutes of Health, National Health, Lung and Blood Institute, the All of Us Scientific Program, the FDA, Office of Minority Health, and the National Alliance for Hispanic Health will provide an overview on Hispanic participation in research studies, specifically longitudinal studies and clinical trials. We will also explore factors such as cultural acculturation and fear, among others, that are barriers for Hispanic enrollment and retention in research studies and efforts being conducted to reach this population. Just a little housekeeping before we get started. All webinar attendees will be placed on mute. If you have any questions during the presentation, please type them into the question box on the right bar of your screen, and we will have time for questions at the end of the webinar. Without further delay, let's get started. Next slide. The opinions, findings, and conclusions expressed by speakers during this webinar are strictly their own and do not necessarily represent the opinion, views, or policies of the Office of the Assistant Secretary for Health, the Office of Minority Health, and the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement. Next slide. Today, I'm pleased to have the opportunity to introduce Dr. Matthew Lin, Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health, to provide us with opening remarks. Under Dr. Lin's leadership, the Office of Minority Health oversees the implementation of the HHS Action Plan to reduce racial and ethnic health disparities and the National Partnership for Action to End Health Disparities and work on key HHS priorities, including the opioid epidemic, sickle cell disease, childhood obesity, and serious mental illness. An orthopedic surgeon, Dr. Lin has spent most of his professional career serving a primarily minority population in the San Gabriel Valley of California, where he served as a member of the board of directors at Al-Habran Hospital and Garfield Medical Center. For the past 2 decades, he has also been involved in medical relief efforts for natural disasters worldwide. Dr. Lin arrived in the U.S. from Taipei in the early 1970s, completing residencies in Baltimore at MedStar Union Memorial Hospital and Johns Hopkins Hospital. He also served on the faculties of the University of Southern California, Western University of Health Sciences, and the California North State University College of Medicine. Welcome, Dr. Lee.
Thank you, Alex. Good afternoon, everyone. Welcome. I'm Dr. Matthew Lin, the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at U.S. Department of Health and Human Services. Thank you for joining us today. As we close out the Hispanic Heritage Month, we want to feature a key issue and highlight the importance of having Latinos representation in research studies. Our mission at OMH is to reduce health disparities and advance health equity for racial and ethnic minorities, and research is a very key aspect of this journey. However, for various reasons, current participation rate in clinical trial do not fully represent the diversity that we enjoy in the United States. For example, the rate of Latino representation in clinical trial is less than 10%, while Latino make up nearly 18% of the U.S. population. Today's speakers are experts in this field. They have a lot to share about the specific of this issue, I want to thank them in advance for helping us gain a better understanding of this ongoing debate. I'm looking forward to learning more about your experience, programs, and opportunity for collaboration as we explore the way to increase Latino participation in clinical trials. Thank you very much.
Thank you, Dr. Lin. Next slide. The objective for today's webinar are to provide an overview of the importance of minority populations' participation in research studies, identify factors that impede Latinos from enrolling in research studies, highlight programs and share resources that might help Latino communities be more involved in research. Next slide. We will now welcome our 4 presenters. Today's presenters are Dr. Gregory Taravera, NIH Soil Study Investigator and Professor at San Diego State University, School of Public Health. Karini Nunez, Senior Public Health Advisor at the FDA, Office of Minority Health. Dr. Maria Lopez Class, Health Disparity Scientist and Program Officer at NIH All of Us Scientific Program. And Edgar Gil Rico, Senior Director for Innovation and Program Development at the National Alliance for Health for Hispanics. Our first presenter, Dr. Gregory Talavera. Dr. Gregory Talavera is a bilingual, bicultural physician with over 30 years of community-based clinical and public health research experience. He obtained his bachelor's degree from the University of California, San Diego, a medical degree from the University of Utah, and his MPH and preventive medicine residency training from the San Diego State University and University of California, a San Diego joint program. Currently, he is a professor in the Graduate School of Public Health at the San Diego State University and founder and co-director of the South Bay Latino Research Center. He has dedicated his clinical practice, research, and advocacy to reducing disparities in the Latino community, both in San Diego and nationally. Over the last 30 years, he has designed and managed research programs involving cardiovascular disease prevention, breast and cervical cancer screening promotion, behavioral intervention for diabetes care, recruitment of minority into long-term clinical trials, and smoking cessation. Since 2006, he has been the principal investigator for the landmark Hispanic Community Health Study of Latinos, a longitudinal study of Latino health in 4 U.S. cities, and the largest study of Latino health in the U.S. Welcome, Dr. Talavera.
Thank you for that introduction, and good morning to everyone, or good afternoon to everyone. So today I'm going to talk about recruitment and retention of Latinos in clinical trials and longitudinal studies using the SOUL Hispanic Community Health Study as a vehicle for that discussion. Next slide. So in order to give you a little background, I think you need to hit the next slide. Yeah, you can go ahead and hit it 2 or 3 more times. Yeah, the Hispanic Community Health Study started about 10 years ago with the primary goal of identifying the prevalence of cardiovascular disease, pulmonary disease, and other conditions in the United States. And of particular emphasis is the last part, diverse backgrounds. The Hispanic Community Health Study is one of the first, probably the largest study in the United States right now that includes individuals of a Hispanic Latino background from all the subpopulation, well, the major subpopulations in the United States. And that's really important message that I wanted to get out. Not only do we need Latinos in our research studies, but we also need diversity within the Hispanic Latino backgrounds, or heritage groups as they're sometimes called. So anyway, the goal of the SOUL study was to address a epidemiologic phenomena in the literature known as the Hispanic paradox, whereby Hispanic Latinos who suffer higher rates of cardiovascular risk factors, lower access to care, poor adherence to chronic disease regimens, even with all of those, they still have lower rates of cardiovascular disease. So in order to study that, you need a longitudinal study, and that's what the SOUL study is. Next slide. This is just a quick overview. The SOUL study is a multi-center trial in 4 cities, San Diego, Miami, Bronx, and Chicago, with a coordinating center at Chapel Hill, North Carolina, and directed by NHLBI. So in the beginning of the study in 2008, we recruited 16,000 people, 4,000 in each site, to be followed over a long period of time, much like similar studies in other racial and ethnic groups, including the Framingham study, which is the largest one to date. And then at visit 2, approximately 5 years later, we still had 12,000 participants and an 80% retention rate. So some of the things that we're learning about longitudinal studies and retention of Latinos into longitudinal studies is really pioneering in terms of what we can share with the rest of the country and the retention of Latinos into long-term studies. So 80%, even though it sounds like a lot, is actually pretty good for an underserved population with all the characteristics that you're well aware of. Next slide. So this is a sample that we ended up with. And again, it emphasizes the diversity of the Latino. We use the word background, but you could also synonymously use the word heritage, but not country of origin, because 20% of our population is US born, and many of the participants were of mixed background or mixed heritage. So as you can see, the Latino is not just simply recent immigrants to the United States. We now, in our study, we have not only immigrants, but immigrants who have been here 5, 10, 15, 20 years in time. We have second generation Latinos and third generation, and some individuals of mixed heritage. So the diversity of the Latino population is really growing in the United States. Here in San Diego, our growth is mainly from birth or natality. So that's another phenomenon that's taking place in some of the more entrenched areas. So as you can see, we need more Latinos from all parts of the country participating in research so we can better understand and generalize our findings. Next slide. So I'm just going to go through some of the barriers and facilitators of recruitment. Next slide. So first thing you will find out if you engage in research is that it's a difficult concept for a lot of our community to understand, and even more so the difference between a clinical trial with randomization and a longitudinal study or cohort studies. So these things, most of them are naive to. They've never been involved in it. They don't talk about it much, and so it can be challenging. And how you present informed consent during this process in an ethical fashion can be a challenge, but it does take time. It takes good translation and people of the culture and the community to really present it. Next slide. So here's some of the things that we found is trust is really probably the key thing. In the SOUL study, we partnered with an established community health center with name recognition, and that gave us a lot of trust. The setting for the examinations were done in the community from which they came. We didn't ask them to come up to the major regional medical center, but we created the South Bay Latino Research Center so they could have their own facilities in the community. And everybody in the research center was culturally competent, bilingual, bicultural, and really engaged in doing it. So it was a friendly environment, linguistically appropriate, decorations were appropriate. It was very, very comforting. Some of the other issues that will be faced is, providing incentives, trying to balance, find that sweet spot between not giving out too much money and people doing it for the wrong reasons, but yet again, not too much so that it's coercive in nature. Next slide. Well, going back to informed consent, one of the things that we did in informed consent is that we developed a layered consent form where, because we were doing behavioral assessments, physical assessments, genetic assessments, we actually allowed people to choose which or any of those they wanted to not participate in. So it wasn't an all or nothing phenomena, and that really helped quite a bit. To diminish some of the potential mistrust that they may have had. Next slide. So it's really important to do ethical work in our population, not simply getting the numbers. You have to be thorough, and the wording has to be as low as literacy as possible. We used videos for our study, which really transcends, some of the literacy issues. You have to be careful if you try doing group consenting, because one person can really sabotage the whole group if you're trying to consent them simultaneously. But I really highly recommend trying to make Spanish language videos for our low literacy population. Next slide. Physician involvement. Next slide. When it comes to working with physicians, practicing physicians, and trying to get them to help refer patients, my experience has been that they're just too busy to really take the time, and particularly if it's a complex study such as SOUL or some of the clinical trials. So generally, you just want to keep them informed of your recruitment activities and what's going on, share the results with them. But largely, it's a difficult task for them to weave that into their daily clinical practice when they're dealing with high volume patient flow. Next slide. Just a few do's and don'ts that we discovered along the way. Next slide. First thing is, don't assume that your participants really are going to be as enthusiastic about the research study as you are. Again, it's often a strange thing. There's some cultural bound beliefs surrounding that. But it really is a strange topic for folks, particularly the LD and the recent immigrants and our minorities in general. Recruitment always takes more time and energy and money than expected, and this is a message I've been trying to deliver to NIH. So been involved in several multi-site trials, and they asked, well, let's just recruit more Latinos into the study, but they don't want to recognize that it takes more time and energy and sensitivity to do that. So keep that in mind. The other thing, particularly as it relates to longitudinal cohorts such as SOUL, is that you don't want to go with easy recruitment. Sometimes people can be motivated by the money, or the recruiters can be over ambitious about selling the study, and yeah, they'll get their recruitment numbers, but they may not. The participants may not have joined for the right reason, and it will lead to difficult adherence and retention rates. So that's probably one of my most key messages out there. Take your time with recruitment, and just remember, easy recruitment can lead to difficult adherence. Next slide. We discovered in our study that patients like results, blood tests, BMI, anything you can give them back, it would be really helpful to retention. Oftentimes the participants are joining because they're uninsured and they just want the health checkup. So that's another thing to keep in mind during your recruitment period. Next slide. So a couple of other quick things to remember. We don't use research when we're talking about the project. We say study or project. We don't talk about endpoints, but we talk about benefits to their health, and really need to promote a philosophy of caring. And sometimes giving for cohort studies, it's really helpful if the physician like myself can give talks to the participants about the results and things like that. Next slide. So we're kind of running out of time, but next slide. We'll go over some of the retention strategies. I think the slides will be available, but these are some of the strategies that we used. Phoning the patients frequently to find out how they're doing, assisting them with referrals when the diagnostics yield new findings such as diabetes or sleep apnea, things like that, and energizing the community with a lot of face-to-face meetings and talks about the study results. Next slide. I'll just let you read through these, but we have one for our retention purposes. We have a sequence of reminders and things that we do to keep them engaged and remind them that they're still in the study. Next slide. Here's another list. The birthday card is really good. We have a calendar that we publish in Spanish every year that's a popular thing. So trying to find out what resonates with your community is really important for retention. Next slide. Okay, I think I'm going to skip over the slide, and I think we'll go to the last slide. Yeah, so to find out more, our website has all the information and publications about the study, all the measures that we used, and you can find it at that website. So I'll stop there and turn it back over to Alex.
Thank you, Dr. Talavera. Just as a reminder, you can type your questions on the chat box, and we will take them after all the presentations. Our next presenter is Karina Nunez, Senior Public Health Advisor at the FDA Office of Minority Health, within the Office of the Commissioner. She is the co-lead for the Outreach and Communications Program within the FDA OMH and the agency's lead for the Language Access Program. Karina Nunez started her career with FDA in 2010 as a public affairs specialist. She has a bachelor's degree in science from the Inter-American University of Puerto Rico, a master's degree in public health with a specialization in health policy and management, and 2 postgraduate degrees in health disease prevention and promotion and healthcare risk management from the Florida International University. She is currently a doctoral candidate in public health at Walden University. With you, Ms. Karina Nunez.
Thank you, Alice, and good afternoon, everyone. Striving for health equity in clinical trials. Next slide. This presentation represents the personal opinions of speaker and does not necessarily represent the views and policies of FDA, and no conflicts of interest to declare. Next slide. Our overview. Next slide. Next slide. The FDA is responsible for protecting the public health by assuring the safety, efficacy, and security of human and veterinary drugs, biological products, medical devices, our nation's food supply, cosmetics, and products that emit radiation. FDA also regulates the manufacturing, marketing, and distribution of tobacco products to protect the public health and to reduce tobacco use among minors. We are a consumer protection agency providing information on regulated products to ensure the safe and effectiveness use for all consumers, patients, and healthcare providers. We are also a regulatory agency at the intersection of commerce, laws, and public health. Next slide. The FDA Office of Minority Health, our mission is to promote and protect the health of diverse populations through research and communication that addresses health disparities. And our vision is to create a world where health equity is a reality for all. Next slide. And in the interest of time, I'm going to leave those the slides for everyone to see at their own leisure. Next slide. Next slide, please. Please go back. FDA is the only agency in the world that does primary review of data ranging from preclinical to clinical. We also establish regulations and guidances about the data in trials and process applications, help raise awareness about clinical trials participation. However, we do not run clinical trials. We make sure the medical products are safe and effective for people to use. And also to learn about this, more about these products. We do not develop any treatments or, as I mentioned before, conduct clinical trials like NIH does. Our work begins after clinical trials are done, and we review data from trials. Important role is that we help raising awareness about study participation. Next slide. Most clinical trials have a glaring flaw before they even begin, and I'll explain on the next slides. Next slide, please. Why do we need minority participation in clinical trials? Trials provide a crucial base of evidence for evaluating whether a medical product is safe and effective. However, historically, racial and ethnic minorities have been underrepresented. For an example of this is more than 17% of the US populations are Latinos, and only 3% participate in industry and sponsored clinical trials, and about 7.6% participate in NIH-sponsored trials. In comparison, currently NIH trials have 30% of minority representation overall. Health disparities exist because of the lack of available information about differences in response to treatments, particularly for diseases where minorities are adversely impacted. Also, variations in genetic coding can make a cancer treatment, for example, more toxic in one ethnic group than it would be in another. Next slide. As I mentioned before, to give you an example of how low minority participation is in clinical trials, African Americans are almost actually 13%.
American heavy metal band in Chicago.
And clinical trial participation is 5% only participation. Also, Latinos are about more than 17% participation, but only roughly a 3% participation. Next slide, please. Some considerations are the prevalence, diagnosis, and treatment patterns, previous subgroup inclusion in past studies, and any clinically meaningful subgroup differences in safety or efficacy. We have evidence that there are racial ethnic-based differences in how individuals respond to drugs. The disease of prevalence, the measurement of all the individuals affected by the disease in question at a particular time are things that we recommend that should be looked at. Also, the diagnosis and treatment patterns of previous subgroups inclusion in previous studies and any clinically meaningful subgroup differences in safety and efficacy is something that should also be looked at. Next slide. Some of the reasons for decreased participation are mistrust of the medical system due to historical abuses, something that we have heard often. The personal experiences, also the inadequate recruitment and retention efforts, lack of awareness on patients' part, privacy, perception that minorities are ineligible for enrollment, a disconnect between research and the community has also been pointed at as one of the reasons for decreasing participation. Next slide. Our take-home message to all our healthcare professionals is simple. Ask patients to participate. In general, minorities will participate if asked. In a research survey, 71% of Latinos who knew what a clinical trial was said that they will consider participating in a clinical trial if asked. Next slide. Next slide, please. In 2012, the FDA passed the Safety and Innovation Act known as FDASIA. More specifically, Section 907 calls for the reporting of inclusion of demographic subgroups in clinical trials and data analysis in applications for drugs, biologics, and devices. A report was issued on August of 2013 to determine the extent of demographic subgroups applications. Also, in August of 2014, the FDA submitted an action plan to Congress outlining the recommendations for improving the completeness and quality of analysis of the data. Next slide, please. There are 3 priorities and strategies on the FDA FDASIA Section 907 action plan. Quality, to improve the completeness and quality of demographic subgroup data collection, reporting, and analysis. And this is done through the collection of race and ethnicity in clinical trials. Also, a revised guidance report of the evaluation and reporting of age, race, and ethnicity data in medical device and clinical studies. Identifying barriers to subgroup enrollment in clinical trials and employing strategies to encourage greater participation. This is done through public meetings, tools to support diverse clinical trial participation, and making demographic subgroup data more available and transparent. And we are doing this through the launching of the drug trials snapshot. Next slide, please. FDASIA 907 also calls for the development of a steering committee. As I mentioned before, we have held a series of meetings with our stakeholders. In 2016, we hosted a public meeting titled Progress on Enhancing the Collection, Analysis, and Availability of Demographic Subgroup Data. And we have also hosted 2 meetings with industry in 2016 with the University of Miami Clinical Trials Symposium, and most recently, last May, the Puerto Rico Clinical Research Summit. Next slide, please. Part of this plan also calls for, we're looking at the expectations that the sponsors enroll participants who reflect the demographics for clinically relevant populations with regard to age, gender, race, and ethnicity. We also, this plan also includes the inclusion of clinically relevant subpopulations should be submitted for discussion to the agency at the earliest phase of development and for drugs and biologics no later than the end of the phase 2 of the meeting. The inadequate participation and/or data analysis from clinical relevant subpopulations can lead to insufficient information pertaining to medical product safety and effectiveness for product labeling. And this is something very important that we call our industry to look at. Next slide, please. As I mentioned before, we have our other driver is to raise awareness about the importance of minority and diverse populations into clinical trials. And with that, we have developed a multifaceted campaign. Next slide. Some of our motivators for this campaign was to add a positive reinforcement as to why minorities' health issues matter. Also, to educate our consumers about key issues and stimulate dialogue among our peers and patient providers. Next slide, please. Using the hashtag Clinical Trials Champion, we launched this campaign in 2016, and with that, we have developed a series of tools and resources available to all for distribution, such as videos, webpage, podcasts, newsletters, stakeholder collaborations, social media posts, and graphics. Next slide. Next slide, please. As you can see, these are some of our videos. They're all available on our YouTube playlist. And please, I encourage everyone to check them out. We not only have worked with us, with our internal stakeholders, but we also have partnered with the VA Department of Veteran Affairs in the creation of some of these videos. And last year, we also launched our very first video, Latinos can make a difference in clinical trials, solely in Spanish. And our main goal to this is to meet people at their place of need. And so we understand that there's no one size fits all to reach our audience. And next slide, please. Most recently, our office entered in a memorandum of understanding with Yale University to continue broaden our outreach efforts and continue raising awareness on the participation in clinical trials. Next slide. I will leave this for people to look at later on. Next slide. These are some samples of some of our resources. Here, our resources are available in multiple languages, including Spanish, as you can see. Next slide. More of our samples of our resources available, and they're available for free to everyone. Next slide. Next slide, please. This is just a small list of some of our stakeholders that we engage in these important conversations and that we currently working with. Next slide. And as I mentioned before, please connect with us. You can find us on Twitter at FDAOMH, and also please don't forget to check out our YouTube playlist. Next slide. Thank you all. Thank you, Alex.
Thank you, Karini. Our third presenter would be Dr. Maria Lopez Class. Dr. Maria Lopez Class is the Healthcare Provider Organization Program Director for PETE, Arizona, Columbia, and Northwestern for the All of Us Research Program. Maria takes a multidimensional perspective to understand the self-care practices and health behaviors. Her skills in methodological and scientific approaches allowed her to study psychological factors and inequities among African Americans, Asians, and in particular, Latino subgroups. Maria has experience with community outreach and health-related research. Before joining the All of Us Research Program, Maria worked at the National Health, Lung, and Blood Institute, where she served as an advisor for the Center for Translation Research and Implementation Science on relevant health inequities initiative and collaborative efforts. Dr. Lopez Class has authored manuscripts related to acculturation, immigration, and chronic disease management. She earned her PhD in social welfare from the State University of Albany, a Master of Science in Epidemiology from the University of Michigan, and a Master in Public Health with a focus on health promotion from San Diego State University. With you, Dr. Maria Lopez Class.
Thank you so much, Alex. Thank you, everyone. I'd like to thank the Office of Minority Health for providing me this opportunity to speak on behalf of the All of Us Research Program. Muy buenas tardes. I'd like to mention that we know that Hispanics and Latinos is one of the largest racial ethnic minorities groups in the U.S. Yet, only a small fraction of medical research participants are Latinos. We need greater participation of this group to help researchers understand and develop treatments for diseases and conditions that are more common among this community. And in doing so, the All of Us Research Program has developed an All of Us Anthem video that is not only in English, but also in Spanish with the help of specific Spanish committee members. And I'd like to take 30 seconds to, I think, a minute to share with you this video that has been developed and has been disseminated across the U.S. Here we go. Thank you. Thank you. I hope that gives you a flavor of what we're doing to outreach to specific Latino populations. Next slide, please. We are, the All of Us is making a positive impact on minority communities, including Latinos, and in doing so, we have provided funding to an array of community partners, including the National Alliance for Hispanic Health, the National Hispanic Medical Association, to name a few. In addition, next slide, please. We extend our NIH funds to consortium members that include not only our community engagement partners, but also to specific HPO, health provider networks, that bring a wealth of experience and in particular who have worked with historically underrepresented populations in biomedical research. I'd like to also highlight that we have funded federally qualified health centers that provide high quality preventive and primary health care. They can help us engage participants from underserved communities. And I also want to bring your attention to Direct Volunteers Network, which is on top of this slide, where this is an additional complement to the regional efforts through the health provider organizations, which is led by Scripps Translational Science Institute, and is supported by Walgreens, WebMed, the Blue Cross Blue Shield Association, and so forth. And so this approach is designed to enroll people across the country, and in particular, the focus will be on underrepresented populations and those in areas not serviced by our health provider awardees. And so I just want to share with you the networks that we're reaching out to bring in and have participants from diverse communities enroll into our All of Us research program. Next slide, please. And so what is the NIH All of Us research program? We're a program that is a longitudinal effort to gather data from 1 million people. We want to do so by taking into account the individual differences in people's lifestyles and their socioeconomic status, in the environments that they live in, their biology. And we hope by gathering the different types of data that I'm going to share with you later, we'll be closer to uncovering the path that leads to individualized prevention, treatment, and care for all population groups. Next, please. And so as we gather this data, it will allow us to answer many questions. For example, how does a person's DNA influence the way a disease or condition affect them? And why do some treatments work for some people, but not others? So for example, why does some treatment work for Cubans, but not Mexicans? And so by having Latinos participate, we are going to help scientists learn more about these populations, and also will help improve health for the communities that we're serving and for future generations to come. Next slide, please. And so why do we even need an All of Us research program? We need it because the time is now, the time where participants, Latinos in particular, are underrepresented, and we need to be able to bring them into research studies so researchers can have a better understanding of their health. And in terms of providers, precision medicine it's in its early infancy, and so by having information about different population groups, doctors can have a better understanding of how to move forward towards individualized treatment. And for researchers, the data that we're going to be collecting that not only encompasses surveys, but also genomics and also different types of clinical specimens, we're getting closer to providing researchers with a wealth of data that will help them understand how to best conduct research with different types of population groups. Next slide, please. So the time is now. The time is now because we have the technologies that can collect and crunch huge amounts of data. The people, the communities are more engaged in their own health, and they're more engaged in tracking their information through Fitbits, through surveys, and we have a better understanding of the human genome. Next slide, please. So this is the potential activities that we're asking of participants in the current protocol. It includes having them enroll, consent, and provide the EHR, the electronic health record. We're asking them to answer specific surveys. Currently, we have 5 surveys that include the basics, demographics, the overall health, their personal habits like alcohol and smoking behavior, healthcare access, family medical history. We're also collecting physical measurements that include blood pressure, body mass index, heart rate, height, rib circumference, weight, and the biospecimens that I mentioned. We're having them at the healthcare provider organization. Their participants provide us with blood samples, in some cases urine if the blood is not easy to collect, and the wearable and digital apps. As I mentioned earlier, the Fitbits, for instance. Next, please. So for Latinos, because we want to make sure we include them, we have currently in the asset portal 130 Spanish assets. Many of these assets are broken down into videos, into PDFs, into co-branded messaging, as well as print-ready materials that talk about EHR, to talk about how do we safeguard their privacy. So these are information that are not only in English, but also in Spanish. And many of this information what has been translated by a Spanish committee of about 30 people from different Latino subgroups. Next, please. We also have recently had a Twitter chat with Salud America, where we asked the question about the importance of Latino participation in health research. Next, please. So I want to share with you very briefly, and this was shared with the first presenter, the diversity of Latino that are from Mexico, from Puerto Rico, from the Dominican Republic, from Cuba, Colombia. So just to give you a flavor of what we currently have in the All of Us Research Program, the different types of Latino subgroups. Next, please. And here, what we're calling core participants are participants that have completed the consent form, have done the physical measurements, and these are the participants. Again, you can see here, I just want to highlight the diversity in the Hispanic and the Latino subgroups. As you can see, we have a large proportion of Mexicans, but as the program gets moving forward, I'm sure we'll be able to increase our numbers in other Latino subgroupings. Next, please. So what I want to share with you here is that with our federally qualified health centers, which are 6 currently funded, one of them is in San Diego, is that we see 33% are of Latino heritage in our federally qualified health centers, which are in our underserved communities. When we look at the next slide, which focus on the health provider organizations, you can see, next slide, please. We have, for Latinos, we have 16%. So that translates into a little over 9,000. And so we are making headway to fill that gap that currently exists with Latinos being underrepresented in biomedical research. Next slide, please. And so before I say thank you, I want to share with you that the All of Us Research Program is embedded with specific core values. One is participation is open to everyone. But the participants reflect that the rich diversity of the U.S. Participants are our partners, and trust will be earned through transparency. We hope to be able to return participants what they give us in terms of surveys, what they provide us in terms of biospecimen, in terms of genomics, and the program currently is a catalyst for positive change in research, but also in individualized medicine. I want to thank you again for your time, and thank you very much.
Our fourth and last presenter is Edgar Hill Rico. Rico is a Senior Director for Innovation and Program Development at the National Alliance for Hispanic Health. For the past 12 years, he has worked on efforts improving health outcomes in Hispanic communities in the areas of cardiovascular health, physical activity, and environmental health. Mr. Hill Rico works on initiatives that foster the sustainability of community-based organizations and efforts to harness new technology to create communities of health and deliver timely health information to consumers. Mr. Hill Rico currently serves as a principal investigator of Todos, Juntos, All of Us Research Program, a Hispanic outreach initiative to educate, motivate, and facilitate enrollment in the All of Us Research Program. He received his master's degree in Business and Community Development from the Copenhagen Business School and has completed advanced executive training in nonprofit management and evaluation at Harvard Kennedy School of Government. Welcome, Jill Rico.
Thank you, Alex, and thank you all for attending our webinar today. I'm going to start the presentation with a brief overview of the Alliance and then some of the data that we have presented about research in Hispanic communities. It's all being addressed by other speakers, so I'm going to skip some of those. But for those of you who don't know the Alliance, we're the largest and oldest network of Hispanic healthcare organizations in the country. Our members serve more than 50 million persons across the country every year. And our mission is to work with all of these organizations to achieve the best health outcomes for all. We do believe in community-based solutions, and all of us is one of those community participatory research programs that we really like. And something we're always proud to say, we do not accept funding from alcohol, tobacco, or sugar sweetened beverage companies in any of our programs. Next slide, please. As you can imagine, we're very interested. We have been advocating for Hispanic community participation in research programs for a long time, and being currently more than 60 million Hispanics in the U.S., the second largest group in the U.S., we're very interested that this particular program really shows the diversity of our community. Next slide, please. As Dr. Talavera mentioned before, all groups are diverse, and Hispanics are very interested because the process of inclusion, how we got here, immigrants or refugee, or acquire status, or the different generations, and how we are common among each other, but also very different. We can have the core Spanish language as a communication, but religion and values for family and all of this is something that really goes around the whole Hispanic community. But within those groups, we really need to look at the subgroups of what makes our community. Next slide, please. For the All of Us research program, in 2017, as Dr. Klaus Lopez mentioned before, we were one of the agencies selected by NIH to bring this work of community partners to support the engagement of diverse communities across the country. We are currently working with Delta Research and Educational Foundation, 50 Forward, San Francisco General Hospital, and the Asian Health Coalition to bring African Americans, Asians, LGBT community, so on and so forth into this program. And based on the experience that we have, for example, when we partner with CMS to do Medicare Part D enrollment, one of our projects was described as one of the more innovative to bring the largest group of Hispanic seniors, more than 500,000 Hispanic seniors receive information of this particular program. And that's the kind of capacity that we want to bring and being able to maximize during this implementation. Next slide, please. And the following one. And as Ms. Nunez has already presented, yes, Hispanics are 17 or 18% of the Hispanic community of the total community in this country, but we are only representing 1% of clinical trials. We know historically that it has shown that variation in drug response has been shown to be by gender, race, and ethnicity. The underrepresentation of Hispanics in health research is clear, but we are also focusing on the representation of Hispanic researchers in research. We know about the issues of mistrusts, lack of partnerships, logistical concerns. Next slide, please. And this is something that we really address through our communication with communities. There are cultural and language issues. There is fear of government programs. People are concerned with confidentiality. The lack of understanding of the U.S. healthcare system is one of the main issues. Next one, please. And if we go down to the nitty-gritty, we know that lack of transportation, working hours, schedules, anti-immigration policies, fear of some communities of just leaving their house for the current local situation are kind of like personal life circumstances that will always prevent Hispanic communities from participating. Next one, please. And as I mentioned before, if researchers don't look like the participants, what's the likelihood that we're also going to feel comfortable participating? We know that Hispanics and African Americans are 25% of the US population, but still they are less than 5% of the NIH principal investigators. So we really hope that once all of us research large database that we're trying to build has all of the data, representation from researchers, which will also show the diversity and the capacities of our community. Next one, please. And next one. Now moving on to the opportunities. We, as Dr. Talavera mentioned before, trust is key in our communities based on years of experience, number of surveys that we have conducted. Hispanics need trusted source of information. They want to receive accurate information from somebody that they know. So for us and for this program, particularly in all of us, we are going to be using a multi-pronged strategy. We're going to be doing a high touch, which is one-to-one counseling, and a high tech, because our communities are diverse, multi-generational, bilingual families that we need to be able to approach each one of those members of the family with something that will resonate with them. Next one, please. Within the high touch activities, something that Dr. Klaas already mentioned that is really good for us in this program is all of us is a fully bilingual program. We have everything available in English and Spanish. Our goal is to educate, motivate, and facilitate enrollment. And as mentioned before, it's not only the incentive. We need the participant to really understand what they are signing off, what their commitment is. And to do this, we're using already trusted platforms that we have. For example, we have the Vive tu Vida Get Moving series of events. This is a 12-year-old initiative in which we have been able to reach 25,000 people annually. We're working with Promotoras de Salud in North Carolina, Illinois, Arizona, California, New Mexico, and Texas. Next one, please. For those locations where we don't have a partnership yet, something that all of us has put and make available for us is the All of Us Journey. This is a traveling exhibit that we have to be able to educate communities about the program. We have been able to bring this unit to schools, churches, street festivals, movie theaters, even to the Ventanillas de Salud at the Mexican consulate to be able to meet the communities where they are. And in addition to that, we are also not only talking to potential participants one-on-one directly, but also with policymakers and city officials and businesses and future researchers to see how they can get involved and support our efforts. Next one, please. As you can imagine, Hispanics are early adopters of technology. Latest research from the Pew Research Center shows that 3/4 of Hispanic that own a smartphone use their smartphone to look for information on health. Half of them take some kind of online or look for educational content related to health. So we have been heavily investing on reaching them through social media, Pandora, etc. Next one, please. We also have already a captive audience based on all the other programs. We have something called the Buena Salud Club, more than 15,000 members, and we have been reaching out to them. At the same time, as I mentioned before, we also want to reach out to professionals, to health professionals, because we want the delivery of the information to be at that point of entry. When the participant is with the doctor, they should also be able to look into the conversation about all of us. Next one, please. And just to finalize, Hispanic media is still critical to success. Our communities really listen to what's going on TV and radio. In the work that we have been doing with different Spanish lingua media, we have found that media is more likely to collaborate with us and help us reaching our Hispanic audience when we are providing resources for the community. Phone banks are very interested tool for us to use. The community really wants to know about the future of health, as all of us is, but also that we have the capacity to connect the communities to the services that they need now has been a perfect complement for the program. So some of the lessons, if you go to the next slide, is that we can use all the technology available, and that's what we're trying to do. But in our communities, the high touch to being with the communities on one-on-one is very important. We already have those trust organizations that we partner with. They are our face in the community. They are the ones who can provide the services now. And we need to understand that there are different events and different tools that we need to use at different times. People are very concerned about confidentiality, but the one-on-one support is what changes really the message that we are delivering. Next slide, please. There is still a road that we have to keep working with, reaching out to Hispanics to participate in research, but this was a message from one participant in Pasco, Washington, in which once the person internalized, Hispanics are very philanthropic, they're very willing to give, as it was mentioned before. And once the person sees that the future of health and a personal family history doesn't want to be repeated, that's something that we will be able to deliver the message that we want. And the last slide, please. So we're very committed. For more information, we have our 1-800 number that reach out to all communities across the country. And we're very excited to see how the All of Us research program keeps growing as it has been done for the past year. Thank you.
Thank you, Edgar. I'm pleased to see that we have an overwhelming number of questions, and we might have more questions than time to address, that we can address. I will try to now ask a couple of questions and see if we can address at least 4 of the questions that we have received. For Dr. Talavera, one of the questions that we have received is, how does it take to build the community trust?
So the question is, how long does it take to build community trust? Well, as it relates to research, I would say years, but it also depends on the size of your community and the efforts that are being made to build that trust. So as an example from Project Soul, we co-branded our materials with a large community health center that had been in the community for over 40 years and represented 90,000 patients in that immediate area. So using their name in our marketing to begin with was very important. I think the other key thing was the actual facility for the study was right in the middle or the heart of the Latino community in the South Bay of San Diego. So that was good. And it really, beyond that, I had practice in that area, so my name had some recognition as well. But I think it's more than all of that. The last thing I would mention is just giving back. What have you done for the community? Are you sharing your results? Are you providing services? Are you involved in the community organizations that are volunteering in that area, the NGOs and so forth? So it does take time. If you have not done research in a particular community and your research entity is trying to move in there, it will take time. And yeah, it's difficult. It's like any relationship. You can't just become friends with somebody. It takes time. You got to have a mutually beneficial relationship.
Thank you, Dr. Talavera. There's a question for Karini, and the question is, with regards to the FDA's multimedia campaign, which of the elements of the campaign has proven to be the most successful in reaching the community?
For us, I have to say the videos will be our top go-to resource that people watch. We are very fortunate to say that our clinical trials videos are the most watched videos for the entire agency. So we're very proud of the product that we have created.
Thank you, Garini. I have a question for here, Rico. And the question is, what are your metrics on individuals actually accessing materials on your site?
Thank you, Alex. Yes, we do have, we keep metrics and we keep measuring not only the access online, we measure the response to the text messaging campaigns, we measure response to the Pandora ads, how many times a brochure gets downloaded. On social media, it's a lot of metrics that are going on, but we also find that a portion of the population still prefer to have the printed paper copy, and that's what they ask for when you want to talk to them. Instead of saying like, go and download something, still the community wants something that you're handing to them and probably use it to talk to them and explain to them what you are trying to say.
Thank you, Hill. One question for Maria that we received is, I just want to know if there are enough training in minority health for Hispanic Latino practitioners, specifically or especially for community health workers that are doing work at the grassroots levels with the community population.
Thank you, Alex, for that question. I think specifically training through NIH right now, no, but it's a good suggestion. But as we think about the healthcare provider organizations, there are some that are incorporating training within their specific sites. I can think of one specific site at the moment where Arizona, which has a promotora model where they're pilot testing and doing training with these promotoras so that so these are familiar faces in the community and reinforcing the importance and the awareness of this program. And through these trusted community people, they're coming to enroll in the program.
Thank you, Maria. There's one more question, our last question, which could be for anyone, or if everyone wants to provide their expertise. The question is there anything that can be done to reduce the concept of research being so strange? Dr. Talavera wants to be.
Can you repeat the question? I think I lost.
Yeah, I didn't hear that. Can you repeat the question?
Yes. Is there anything that can be done to reduce the concept of research being so strange?
Oh, that's that's going to take quite a bit of community education throughout our networks and every facet of society to try to get that more familiar to people. So yeah, that's kind of like public health education. I don't think there's one specific thing I can mention, but you know, what we're doing in our community health center is you know, just doing more research and putting recruitment flyers in the waiting rooms and the waiting room TVs promote the television. So I think only through, you know, experience and you know, diffusion of innovation concepts can we really begin to address that issue. Sorry, that's a tough one.
Anyone that would like to add to what Dr. Talavera shared with us?
Hi, this is Karini. I agree with Dr. Talavera, and one of the main comment I would say that we receive from consumers oftentimes is, well, my doctor hasn't told me anything about clinical trials. My doctor doesn't talk to me. So for us is, as I mentioned during my presentation, is this is it is definitely has to be a multifaceted, approach. There is no one size fits all to reach out to all these, to all our communities. It's not only our Latino communities, but also our Black communities, our Asian Americans communities, and so forth. But just to give you an example, we start by having conversations with with our stakeholders and people that are working in those with those populations, and learning what worked for them, and try to address them accordingly. And also, this is the work that you do with consumers is only a part of it. It's only 50% of the work. You have to also include the research community, your healthcare professionals as well, and bring them to the table to talk to them. And for us, in our case, FDA being a regulatory agency, we do not conduct clinical trials, but we reach out to industry and have conversations with them and raise awareness and try to make the case and say, hey, we need more minority participation into clinical trials, and this is why. So again, I agree with Dr. Talavera. It's a tough question, but you have to be. It's a constant effort. It's an ongoing effort.
Thank you, Karini. I think on behalf of OMH, we want to thank again Dr. Lin for being with us today, and thank you all of our presenters for such an excellent and thought-provoking presentations. On behalf of OMH and our partners, I want to thank also you again for joining us today. For more information about the Office of Minority Health, please visit minorityhealth.hhs.gov. Thanks.